स्क्रीन आ रही है, स्क्रीन नजर आ रही है ना भाई? वो आ रही हो कह रहे थे जी। हेलो, अस्सलाम वालेकुम, बिस्मिल्लाहिर्रहमानिर्रहीम. This is Dr. Nadeem Hassan, currently designated as the director of National Institute of Liver and Gastrointestinal Diseases at our University of Health Sciences. So today my topic presentation is going to be liver abscesses and masses. So we will step by step dissect different lesions that are seen in the liver and discuss about the approach to diagnosis and the management. So to begin with, the first topic would be regarding the liver neoplasms. Neoplasms in the liver can be classified as benign or malignant. Benign lesions, the most common amongst them are the hemangiomas, which are the commonest findings when we performed some non-invasive radiographic radiological maneuvers like ultrasound. The other lesions of the benign lesions are the adenoma, focal regenerative hyperplasia, simple hepatic cyst, and the polycystic liver disease. So these are the broad categories of the benign liver neoplasms. Amongst the malignant liver neoplasms are the hepatocellular carcinoma, cholangiocarcinoma, metastatic liver disease, and lymphoma. So these are the broad categories of the malignant lesions seen in the liver. The hepatocellular carcinoma is the cancer of the liver parenchyma itself. Cholangiocarcinoma arises from the collecting system, from the biliary system, whether it could be intrahepatic or extrahepatic. Then we have different lesions seen in the liver which metastasize from other locations, like from colon, from breast, and other locations, and other viscerals as well, and then the lymphomas. So before we proceed to identify the different lesions, how they can be identified on CT scan, we'll first like to proceed with the basic functionality of the CT scan. So how we are able to elicit the lesions in the liver based upon the different phases of and the timing of the contrast injection. So as we all know that liver has a dual blood supply. The normal parenchyma is supplied by the portal vein. 80% of the liver parenchyma is supplied by the portal vein, and only 20% of the liver parenchyma supplied by the hepatic artery. So keeping that in mind, we can actually utilize this anatomic distribution, the blood supply distribution of to the liver, that may help us to differentiate different lesions. So based upon once the contrast is injected into the vein and then circulates through the system, then based upon the appearance of the contrast in the liver, different lesions can be identified. Some lesions are seen in the early phase, some in the later phase, and some throughout. So based upon the timing of the contrast appearing in the liver lesions, we can identify and try to describe and classify different lesions. So all the liver tumors get 100% of the blood supply from the hepatic artery. So we have to keep this in mind. So initially, once the contrast is injected, so initial part is arterial phase. Say in the arterial phase, the hypervascular tumors will enhance via the hepatic artery. when the normal parenchyma does not yet enhance this. And the reason is again because the contrast is not yet in the portal venous system yet. So keeping that in consideration, so lesions that will be hypervascular would show up in the arterial phase in the early part of the CT scanning. Optimally, the hypervascular tumors, they enhance at about 35 seconds after the contrast injection. The next is the portal venous phase, and this phase is basically to detect the hypovascular tumors, tumors that have they are less avid to the blood supply, so they are hypovascular. So those regions will be picked up in the portal venous phase, and the scanning is about at about 75 seconds after the injection of the contrast. And then third comes the delayed phase. In the delayed phase, which begins about 3 to 4 minutes after the contrast injection, and imaging is best done at 10 minutes of the start of the study. Now, the hepatocellular carcinoma, they tend to have washout, and as a result, in the delayed phase, we won't be able to see the contrast in the lesion. So that is a valuable piece of information for the hepatocellular carcinoma. Whereas, example like a hemangioma, they tend to retain the contrast. So even in the delayed phase, we would see the contrast in the lesion. And similarly, the contrast will be retained in the fibrous tissue, like the capsule of the hepatocellular carcinoma and the central scar of the focal nodular hyperplasia. So keeping that in mind, we can see the lesions in different phases. The initial is the arterial phase, the next will be the portal venous phase, and then finally the delayed phase. So based upon this information, we are able to classify the lesions into different categories, and that best and it helps us to classify the tumor based upon the CT scanning. So this is a picture of different phases of the focal nodular hyperplasia. So as we mentioned that the central scar of the focal nodular hyperplasia remains visible in the delayed phase. So let's look at it here. So the first picture over the left upper corner, the picture A, is showing the typical focal nodular hyperplasia, and that is in the pre-contrast phase. That is before the contrast is given. We take a CT scan imaging, and then that tells us there is a lesion in the right lobe of the liver. And as the contrast is injected, we see that in on the right upper corner, B, which is the arterial phase, where the contrast is taken up by the focal nodular hyperplasia, and subsequently we see in the portal phase. In the portal phase, the contrast seems to disappear in the portal venous phase, but once we go to the equilibrium phase, which is the right lower corner, picture D, we see that there is evidence of central scarring. So that is seen in focal nodular hyperplasia. So we'll skip this and then we'll have a picture of hepatic hemangioma. And as we described earlier, that the hemangioma tend to retain contrast, whether it be a plain CT or it get enhanced in the arterial phase, remains in the portal phase, and also in the equilibrium phase. So from left going all the way to the right of the CT in different phases, we are able to tell, this is based upon the CT scan finding, that this is hepatic hemangioma. As a contrast, in the equilibrium phase also is being retained in the hepatic angioma. So hepatic hemangiomas are the most common benign hepatic masses. They mostly are localized in the right lobe, and in 90% of the cases, they are solitary. And it is predominantly seen in the females. More than 80% occur in females. There's no treatment of asymptomatic hemangiomas. The treatment for hepatic hemangiomas would be only if they are symptomatic, if they're having pain, if the size is too big, or they're approaching the surface of the liver. Then in those cases would be the indications where one has to think of surgical intervention for the resection of these hepatic hemangiomas. Except this scenario, we'll get to the hepatic adenomas. Hepatic adenomas are usually solitary. They occasionally are multiple, and what actually happens is that the hepatocytes are separated by dilated vascular sinusoids. So, and on ultrasound or CT scan, they would appear as usually solitary, but occasionally there may be multiple lesions. Risk factors for developing hepatic adenoma are the use of oral contraceptive use, and glycogen storage diseases can also predispose towards hepatic adenoma. In imaging studies, what we find is that they are hypervascular, and they are homogeneous, or they may be heterogeneous. There is lipid accumulation there, and you might see hemorrhage and calcification with necrosis. Capsule is seen, which is more seen in the case of MRI rather than CT. And so those are the lesions. They're benign lesions, so we keep that in mind. So hepatic adenoma, rare hepatic tumor. Females are predominantly affected, 80%, as you saw in our previous slides. And then they are seen in childbearing age. They are related to, or the predisposing factors for the hepatic adenoma are related to oral contraceptive medication, pregnancy, glycogen storage disease, and use of androgens. Androgen steroids are the predisposing factor. Usually asymptomatic, but complications can be seen, and they can be life-threatening, which includes rupture and malignant transformation, which is treatment again is surgical resection for this hepatic adenoma. Skip this case scenario. Now next we come on to the hepatocellular carcinoma. Now hepatocellular carcinoma, as we all know, is a sequelae of cirrhosis. So once a person develops chronic liver disease due to any etiology, whether it be viral hepatitis B or C or D, or any other causes, metabolic diseases, autoimmune. So once cirrhosis or fatty liver for that reason. So once the hepatocellular carcinoma sets in the setting of cirrhosis, so what do we see on the CT scan? So here are different phases of the CT scan. As you can see on the left, it's left bottom, there's a plain CT scan, which only tells us that there's a lesion in the right lobe of the liver, and that is other lesions as well, small lesions are seen as well. but the large one is the right lobe of the liver. And so it is appearing like a hypodense lesion on the CT scan compared to the other parenchyma. And once we go to the arterial phase, and these lesions are contrast avid, so basically it lights up in the arterial phase, as we can see in the second picture. And then once we come to the portal phase, then there is a rapid washout. As you can see, the contrast has sort of washed out from this lesion. And coming back to the equilibrium phase, as we had mentioned earlier, that the capsule surrounding the lesion, it tends to light up, which we are seeing in this top, bottom right side of the CT scan. So these are different phases that helps us tell us that this is a hepatocellular carcinoma. And as I mentioned earlier, that this lesion is hypervascular with the early washout seen in the portal phase. Now, once, as I mentioned earlier, that the hepatocellular carcinoma predominantly sets in the setting of cirrhosis. So patients, how we establish the diagnosis. So based upon the labs, we can check for the tumor marker, alpha fetoprotein, which would be, if it is more than 400, then that is basically complementing the diagnosis of hepatocellular carcinoma. So based upon the CT scan finding or the MRI finding, and alpha fetoprotein more than 400, then we can say for absolute surety that this is a hepatocellular carcinoma. So two modalities, either CT scan and MRI, or we see a CT scan and elevated alpha fetoprotein levels, and that helps establish the diagnosis, and we don't need to do a biopsy of the lesion. These patients tend to have other parameters in the labs out of normal range. The PT-INR is elevated in these patients, platelets are low, and also the liver enzymes are raised as well. The albumin will be low in this patient because of chronic liver disease and cirrhosis. So we calculate the CTP score for this patient, which is using the 5 parameters, including the bilirubin, the PT-INR, albumin, encephalopathy, and ascites. So these 5 parameters are used and to establish the CTP score, that is the child Turcat pure score. And then CTP score tells us the severity of the disease. And then the ECOG score is basically, or the status is utilized to determine if the patient would be a candidate for surgical intervention, whether it be resection versus transplantation. Management depends upon the level of the disease, or the stage of the disease, whether it is a single lesion versus multiple lesions, and if multiple, then what is the size of a single and multiple lesions added up together, whether the tumor has invaded any vessel, whether it be artery or vein, or whether there is a thrombus in the vein, portal vein, the hepatic vein. So those determine the outcome, whether person is a surgical candidate or not. And similarly, if doing a disease status determination by doing a CT scan of the other area like chest would tell us if the disease is metastasized in the chest or in the other parts of the abdomen. And based upon the size, it may be resectable, or the patient may need a liver transplantation, or the patient may not be a candidate for either of these interventions, and the patient may need just medication management and palliative care, and management of the complications that develop because of the chronic liver disease and the hepatocellular carcinoma itself. Currently in Pakistan, sorafenib is being used for such cases who are rendered inoperable. Other managements that can be performed for these lesions are done by the vascular intervention radiology, which includes TACE, TACE, transarterial chemoembolization. Another modality is RFA, radiofrequency ablation, RFA. So a microwave treatment is another modality for treatment of the hepatocellular carcinoma. At times, these measures are used to downgrade the tumor, and then they may be candidate for surgical intervention. Let's give this case scenario. Now, in terms of metastatic liver disease, if the liver shows lesions which may be suggestive of metastatic liver disease, then we have to look for the primary. So the primary in the GI tract, we have to do a endoscopy and a colonoscopy to look for the lesions, and the CT scan or the MRI would tell us if there is any lesion anywhere else. So the lesions may be in the female genital tract, ovarian, or other sites, or it may be in the stomach and the colon. Small bowel cancers are rare. So we have to complete the workup to look for the primary in case if you're suspecting a metastatic liver disease. Management depends upon the primary malignancy itself. For example, if the person has a pancreatic malignancy and showing signs of biliary obstruction, the patient may need the relief of the obstruction by ERCP and stenting or percutaneous transhepatic cholangiogram with the external biliary drain placement. So it all depends upon the primary disease as a part of the workup, and then we manage it accordingly. We do the tumor markers also that helps us in complementing the to establish the diagnosis as well. We'll skip this case scenarios. Now this is a case of cholangiocarcinoma. As you can see, this is an ERCP, which is endoscopic retrograde cholangiopancreatography. So as you are able to see that this is the pancreatic duct, and this is the common bile duct, and what we see here is a structure in the common biliary common hepatic duct system. And then here is the left hepatic duct, and this is the right hepatic duct. And this structure that is marked here, it's from cholangiocarcinoma. We're also seeing that the gallbladder is not filling, so this cholangiocarcinoma is not permitting the contrast going through the cystic duct into the gallbladder. So this is primary cholangiocarcinoma by radiographic appearance. And we can establish a diagnosis by doing a brushing cytology. The yield is low, is about 60% at the best. And these lesions tend to metastasize to the liver as well. So we may see multiple or single lesions in the liver as well as a metastatic process. So regarding cholangiocarcinoma diagnosis, the patient may present a clinical history of jaundice, weight loss, decreased appetite, and then once you do the workup, which may include ultrasound that may show dilated intrahepatic ducts, obviously in the labs, we would see a higher TBL, alkaline phosphatase, GGT, some elevation of SGOT and SGPT as well. And then you do a CT scan. CT scan would tell us that there is a mass causing obstruction of the biliary system. Final confirmation would be both diagnostic and therapeutic as well, is doing an ERCP. We can also do MRCP, magnetic resonance cholangiopancreatography. That will tell us that there is a lesion in the biliary system causing obstruction. And then the ERCP would also endorse and confirm that. ERCP would be therapeutic as well, as we can place a stent to bridge that structure and to relieve the obstruction, so that the bile will drain and the bilirubin liver enzymes would come down. And based upon further workup, a patient may or may not be a surgical candidate. If the person already has metastatic disease or is causing obstruction of the adjacent viscera or invasion of the vessels, then person may not be a candidate for surgery. Very aggressive tumor, life expectancy may be in the range of 3 to 6 months. So most of the patients end up having palliative care. But if the lesion would have been higher up at the bifurcation of the common hepatic ducts, which is called a Klatskin tumor, and if it's still early disease, then patient may be a candidate for liver transplantation. So again, depending upon the extent of the disease, metastasis, different modalities for management can be utilized. And obviously, these patients tend to have a high tumor marker of CA19-9. That's one of the blood tests that we can order as a tumor marker to complement our diagnosis. We'll accept this scenario. So this was ultrasound, Doppler ultrasound, basically showing multiple lesions in the liver. The blue and the reds are the vessels, whereas the blacks that what you're seeing is metastatic disease seen in the liver, which is seen on the CT scan as well. There's hypervascular lesions, multiple lesions in the liver. So this is metastatic disease to the liver. So moving on to abscesses. So this is a life cycle of Entamoeba histolytica, and as you can see that the Entamoeba histolytica enters into the human GI tract, then it affects the gut, predominantly in the large bowel, and from there the parasite travels to the liver, and then it forms abscesses in the liver. One of the key features of the amoebic liver abscesses is that they are multiple, as opposed to the pyogenic abscess, which usually are single. So this is the life cycle for the amoebic liver abscesses. So for the pathogenesis is this ingestion of the cyst, then excistation in the small intestine, and the production of trophozoites, which then subsequently forms flask-shaped ulcers, mostly in the cecum, the transverse sigmoid colon. Tissue invasion then may occur, and the cyst later on exists and then exits from the host in the stool, or they migrate in the bloodstream via the portal circulation. It goes to the liver, and from the liver they form amoebic liver abscesses. These are liver abscesses that are seen. So this is the life cycle for the pathogenesis of amoebic liver abscess. The management of the amoebic liver abscesses is use of metronidazole as the treatment of choice in 95% of the patients with amoebic liver abscesses. They recover with this alone, and most patients show a response to treatment within 72 hours to 96 hours. So within 3 days to 4 days, we tend to see the response. Diloxanide furoate is prescribed for 10 days to eliminate the intestinal amoebae after the abscess has been successfully treated. Then moving on to so if there's fungal and abscesses as well, then we use amphotericin B for the fungal abscesses. So as coming back to the amoebic abscesses, the key treatment is metronidazole, and subsequently after elimination or completion of the course, then we use diloxanide furoate to eliminate the intestinal amoebae. This is a picture showing the drainage of amoebic liver abscess, and this is very characteristic, described as anchovy paste. So this is how the amoebic liver abscess drainage looks like. This is a bottle of anchovies sauce, and then the amoebic abscess, which you can see it looks almost similar. So that's how it got its name, as anchovy paste of amoebic liver abscess pus. So these are the treatment for the amoebic liver abscess at different doses for adults and pediatrics. So predominantly, as you said, that is metronidazole gets rid of the abscess in about 95% of the cases. Another medication will be tinidazole, which may not be available in all parts of the world. And the luminal cyst that we can get eliminated with idaquinone or paramomycin. These are different doses for adult and pediatric population. What are the indications for aspiration of amoebic liver abscesses? So one would be if you're in doubt whether it's a pyogenic abscess versus amoebic liver abscess. So if you're in doubt, then you can stick a needle and then see what comes out and send it to the lab as well. So as I mentioned earlier, the pyogenic liver abscesses tend to be predominantly single, whereas amoebic abscesses are multiple. This could be as adjunct to the medical therapy if there's no response in 72 hours. If you suspect that the rupture would be imminent, then you use drainage of these abscesses. And if the abscess is in the left lobe, the risk of rupture is high. So that would be indication. The possible indication is to reduce the period of disability to the patient. So these are the different indications for drainage out of the aspiration of amoebic liver abscess. Again, we can check for the response to the antibiotics for the management and diagnosis, and check the titers for the amoebic serology. So just a slide to show the comparison. As I mentioned earlier, that pyogenic liver abscesses are usually multiple, whereas amoebic liver abscesses are single. So this is one of the differentiating factor, that amoebic liver abscess is usually single, whereas pyogenic liver abscess is often multiple. Location may be in either lobe of the liver, whereas the amoebic liver abscess is usually in the right hepatic lobe near the diaphragm. Presentation of pyogenic liver abscesses is subacute, whereas that of liver abscess is acute. Pyogenic liver abscesses are mild, whereas amoebic liver abscesses are moderately jaundiced. So that helps the person to look at the clinical jaundice and also the labs. So how we establish the diagnosis, both by ultrasound and CT, and we can check the amoebic serology for liver abscesses, which is usually single, whereas pyogenic liver abscess is usually multiple. And the treatment for pyogenic liver abscess is drainage plus antibiotics, and that for amoebic liver abscess usually subsides with the use of metronidazole, tinidazole, and luminal amoebicidal medication. So those are the differentiating features. So keep in mind that pyogenic liver abscesses, they tend to be often multiple, whereas amoebic liver abscess is usually single. So that's one of the key point that helps differentiate amoebic single, pyogenic multiple. Now we come to the topic of what are the different cystic lesions that may affect the liver. So as we talked about the pyogenic liver abscesses, as we discussed, this is usually multiple, amoebic liver is usually single, and then the highlighted cyst from echinococcus granulosus infection. So these are the in the category of infectious. Then there may be congenital cysts as well, simple hepatic cysts, or the polycystic liver diseases. Cystic lesions in the liver which may be neoplastic, could be cyst adenoma or cyst adenocarcinoma, or the cyst may be after trauma. These are broad categories. It's infectious, pyogenic, amoebic, highlighted cysts are the commonest. Congenital, simple hepatic cysts, polycystic liver disease, the neoplastic cyst adenoma, cyst adenocarcinoma, and traumatic, post-traumatic. So the pyogenic, coming to the pyogenic liver abscesses, it was usually thought earlier that appendicitis is the cause, and that will be described in the literature as well. But we see that pyogenic liver abscesses can develop from infection of the bile duct, from ascending cholangitis, and then they can form liver abscesses. It can develop from the infection of the portal vein causing phlebitis. It can be because of appendicitis or diverticulitis, can cause infection in the liver and can lead to pyogenic liver abscess. Pyogenic liver abscess can develop because of direct extension from the contiguous disease, so adjoining viscerous, be it stomach, be it colon, other viscerous, can cause direct extension and cause pyogenic liver abscess. And pyogenic liver abscess can be because of trauma due to blunt or penetrating injuries. Septicemia can cause pyogenic liver abscesses and could be cryptogenic. I remember one case where the person had ingested accidentally a fish bone, and we did not notice any consequences immediately, but maybe a couple of years down the road. He had presented with a lesion in the liver, a collection, an abscess in the liver, which was drained. Later on, he had a recurrence of that abscess and had required surgical resection, and in that specimen, a fish bone was found. So the fish bone actually traversed from the small bowel through the capsule of the liver, basically penetrated, went through and through from the small bowel, from the duodenum, through the capsule of the liver, and then subsequently lodged into the liver and subsequently developed hepatic abscess. So coming to the pyogenic liver abscesses, the cause that we described could be direct trauma to the liver via some percutaneous procedure, or extension from the gallbladder or subdiaphragmatic process. So this is how liver abscesses can develop. They can extend from the biliary tract, whether it be cholecystitis, with the CVD stone, could be malignant primary or secondary, and then choledochal obstruction from CVD obstruction can lead to cholangitis and liver abscesses. From hepatic artery sepsis, septicemia can develop and then can lead to liver abscesses. And in disease like Crohn's disease, they can lead to infection of the portal vein, and that can lead towards pyogenic liver abscesses as well. And then other areas of the GI tract, for like example, appendicitis, can subsequently lead towards hepatic abscesses, or diverticulitis can lead to hepatic abscesses, pyogenic liver abscesses. So what are the predisposing conditions for hepatocellular liver abscesses in adults? Diabetes, cirrhosis, pancreatitis, chronic peptic ulcer disease, inflammatory bowel disease, jaundice, pyelonephritis, malignancy, leukemia, lymphoma, chemotherapy, steroids, AIDS. So these are the predisposing factors in adults. Whereas in children, maybe sickle cell anemia, leukemia, polycystic liver disease, congenital hepatofibrosis, and necrotizing enterocolitis. So a bunch of other causes in children needs to be looked into to look for the cause of the pyogenic liver abscess. So coming to the pyogenic liver abscesses, do you have multiple? The site is predominantly mostly seen in the right side. The most common organisms are the gram-negative aerobes. 55% of the positive aerobes, example, E. coli, Klebsiella, Enterococcus, and in AIDS patients it is Mycobacterium. So commonly it is in the right lobe. There might be both lobes, about 22% of the cases, and isolated in the left lobe. So if they are solitary, they're usually large. For example, like a portal traumatic or progenitor, they're multiple, they are small. As you bipolar seen in both the sides. I also keep in mind the fungal abscesses can occur in patients, the immunocompromised patients who is receiving chemotherapy, steroids. So any immunosuppressive states may lead towards fungal abscesses as well. So as I mentioned, it can come from the biliary tract, or they could be coming from portal vein or from the hepatic artery. So those are different potential sources that they can get the infection from different other viscera. For imaging, we'll do ultrasound and CT scan, with a sensitivity of 85-90%. Aspiration can be done for diagnosis and microbiological testing. And we come across diagnoses maybe troublesome in patients who are morbidly obese and who have inhomogeneous liver. CT scan has a sensitivity of about 95 to 100%. Ultrasound has sensitivity of 85 to 90%. So CT is more sensitive. And then we would tend to see hypoattenuated compared to the, if you see this lesion here, which is a collection, as compared to the normal liver, this is hypoattenuated, and it enhances well on the contrast. So this is also again hypoattenuated lesion in the liver. MRI is another modality that can help determine the diagnosis, help in diagnosis of pyogenic liver abscesses. Management of pyogenic liver abscesses, antibiotics alone, if they are smaller and no concurrent surgical disease intervention needed. Antibiotics can be given for preferably for 6 weeks. 2 weeks may suffice. Tend to use aminoglycosides or fluoroquinolones, clindamycin, or metronidazole, ampicillin, or vancomycin. So other thing is keeping in mind that based upon the resistance of bacteria in different localities, you have to tailor the antibiotics appropriately. Sometimes we tend to use a single agent like ticarcillin, clavulanic acid, imipenem, and cilistin, piperacillin, and tazobactam. And again, once you get if you have aspirated, you get a blood culture report, or you get a aspirate report, then you can tailor the antibiotics accordingly based upon the sensitivity of the bacteria to the medication. Complications that may develop from abscess is generalized sepsis, which is most common, pleural effusion, empyema, and pneumonia. You can develop contiguous spread of the abscess into the lungs as well. Intraperitoneal rupture, which can be frequently fatal, perihepatic abscesses. Hemophilia, which is blood coming into the biliary tract and from there to the ampulla into the small bowel. Hepatic vein thrombosis is a potential complication of pyogenic liver abscesses. Let's give the scenario. Now we come to the parasites. So this is the life cycle of Echinococcus granulosus. So dog, sheep are the intermediary host. Definitive host is the dog, and it affects the human being as well. As once the human being affected, most commonly the cyst and lodges itself in the liver. Predominantly in the liver, 50 to 75% of the cases, and then go to the lungs in 25% of the cases. The characteristics is that it affects the right lobe, 80% of the cases, 20% of the cases in the left lobe. They're slow growing, 1 centimeter for the first 6 months, 2 to 3 centimeters per year. 75% are solitary, and 50% are multilocular, containing daughter cysts. This is the picture of the cyst anatomy. And treatment is use of mebendazole, albendazole. At times it needs surgical intervention to remove the cyst. Again, we end here with the lecture. Thank you.